Whenever we are discussing the vascular disorders that are occurring at the retinal level, we should consider that we have the basic two systems that we should consider or we should keep in our mind. That is, one on hand, we have the arterial system, and on the other hand, we have the venous system. So basically, we are dealing with the central retinal artery occlusion, or either it can be the central retinal vein occlusion over here. What are the causative factors which can lead towards these vascular accidents? Mainly, we will be considering the ambulous formation, atherosclerosis. Then there are a lot of diseases in which we have hypercoagulability states over there. It can be polycythemia or even a lot of drugs, for example, oral contraceptives are very notorious for the development of these vascular accidents that occur at the retinal level. What will be the outcomes towards these retinal accidents? It would be basically a decrease in the visual acuity, sometimes towards a level of almost 3/60 vision loss in a particular patient. And a lot of patients, it can be even finger counting level of the visual acuity loss. This is the level of damage that can occur due to these vascular accidents that are occurring at the retinal levels. So these are quite complicated conditions, and you should know the severity of these conditions, how to treat these conditions, and what are the different complications towards the particular accident that we are dealing with. We have the vascular disorders of retina that will be discussed over here in this particular lecture. As we were already considering, we have the retinal artery occlusions at our hand. Then mainly we have the retinal vein occlusions. When we compare these two varieties, it is usually the retinal vein occlusion that is more common in the individuals rather than the retinal artery occlusion. Although both are quite severe and both can be manifested as the complicated states in which the visual acuity is severely affected. Then moving on, we have a lot of systemic illnesses that even manifest as the vascular accidents. They have their own fundus findings that we have to be very peculiar about, and they are very characteristic of that particular systemic illness. For example, we'll be discussing the diabetic retinopathy over here, which is obviously related to the uncontrolled diabetes mellitus in a patient. Then moreover, we'll be discussing the hypertensive retinopathy. Obviously, when we are discussing the hypertension, it can be a chronic hypertension as well as it can be a malignant hypertensive retinopathic condition. If we have a controlled hypertension or even the mild cases of hypertension, they're not severely affecting the retina. On the other hand, we have the malignant hypertension, which is severely affecting all of the end organs of the body, which basically includes the kidneys, heart, lungs, brain, eyes. All of these organs are being affected due to this malignant hypertension kind of variety. We'll be dealing with the sickle cell retinopathy, which is again one of the hypercoagulability states of the body, in which the thickness of the blood is somehow quite hypercoagulable, and that is basically causing the compromise of the retinal arteries as well as the retinal veins. So all of these conditions, which includes basically the sickle cell retinopathies, or even a lot of conditions, for example, migraine sometimes, or it can be the amaurosis fugax, in which there is the angiospasm due to idiopathic reasons. So usually the vessels go in a spasm due to some unknown reasons, and that again can be the compromising factor for the veins and the arteries, and that is basically affecting any of the structures that is involving the retina. Then we have the retinopathy of prematurity. So sometimes the retinopathies can manifest as the congenital disorders, and that will be discussed over here. And then the causative factors, for example, the retinal telangiectasias. These are again one of the congenital or the hereditary conditions in which Again, the retina is being affected, the end organs are being affected, and that is going to affect the vision of that particular person. So these are the range of the vascular disorders, the range of the causative factors that can finally affect the vessels of the retina. They have their own fundus findings while we're performing the ophthalmoscopy or while we're performing the fundoscopy. We'll find out that they have their own characteristic findings. For example, the diabetic retinopathy will be finding the cotton wool spots. So these cotton wool spots, these terminologies, you should try to remember them, and that will be the baseline when you are giving out your final diagnosis in a particular patient, that this particular retinopathy is caused due to this particular factor. The investigations will be carried out accordingly. You'll perform all the baseline investigations in these individuals, including the blood CPs and then the LFTs, RFTs. The systemic illnesses are being covered. ESRs are carried out to rule out any infectious states in these individuals. So these will be the baseline investigations that you're going to carry out, and the ocular examination is obviously being carried out in a very systemic manner, starting off with the visual acuity in that particular patient using the Snellen's charts, and then you're going to perform the color visions using the Ishihara's charts. The visual field effects will be diagnosed by using the Amsler grids. So these will be the diagnostic tests when you are peculiarly you're peculiarly diagnosing any ocular manifestations in that particular patient. And on the other hand, you're going to carry out the baseline investigations in these particular patients in whom you're suspecting that this particular patient is suffering from some sort of a vascular retinopathy. So this will be the lab workup that you're going to carry out in these patients. Then obviously moving on to the central retinal vein occlusion, we have this particular variety of central retinal vein occlusion. Again, it's quite common than the central retinal artery occlusion. It is quite commonly occurring in the 6th or the 7th decade of life. The etiology usually can be the pressures that are being exerted from outside. It's one of the causative factors for the development of the retinal vein occlusions. And these are the particular findings that you're going to see in this particular patient. You're going to look for the edema. So it can be the papilledema, that is if it is occurring at the optic disc, then we're going to consider it to be the papilledema. It can involve the other retinal structures. It can be the macular edema as well. So all these structures which appear basically pale on fundoscopy, you're going to look for that. And if it is involving particular structures, for example, the fovea, macula, or the optic disc, then they will have their own clinical signs and symptoms. For example, if it is involving the macula, it is going to affect the most central vision of that particular patient. So these are the findings that you're going to look for in this particular patient. Then the hemorrhages. Hemorrhages are not quite flame-shaped or elongated. They're quite circular hemorrhages, dotted hemorrhages that you're going to see. So this patchy hemorrhage pattern is usually seen in this particular phenomena. The etiology of retinal vein occlusions. What are the causative factors that they are going to end up in the retinal vein occlusion in this particular patient? The etiologies would include the raised intraocular, intracranial pressure. So it's basically the posterior chamber. The chamber pressure is again very important, and that is going to finally affect the optic nerve as well, and finally damage the optic nerve as well. So this is the basic cause of the formation of the retinal vein occlusions. When we are saying that it's basically the raised intraocular pressure in the posterior chamber, it can again be caused due to multiple reasons. All of the reasons that we have already discussed in the section of glaucoma. a separate lecture, a separate entity that we discussed separately, which basically dealt with in the causative factors of glaucoma, will further enhance the secondary causes of the formation of glaucoma or increased intraocular pressure. This increased intraocular pressure in return is going to affect the arteries, the venules, the optic nerve, all of these structures that are present in the posterior chamber. They're going to be affected by the increased intraocular pressure. Then we have the hyperviscosity of the blood. As we have discussed, there are a range of conditions in which we see this hyperviscosity of blood, ranging from the APS, ranging from the Sjogren syndrome, and then we have the use of the oral contraceptives. So these are mainly the conditions in which we experience the hyperviscosity of the blood. APS is basically the antiphospholipid syndrome that is responsible for the hyperviscosity of blood, and that is going to in return cause the stasis of the blood in the vessels, may it be the arteries or the veins. And then in return, obviously, it's going to cause the non-ischemic kind of central vein occlusions in this particular patient. We are even going to discuss the differences between the non-ischemic and the ischemic variety further on. But over here, moving on with the etiological factors, diabetes mellitus is one of the causative factors, which is again going to manifest as these retinal vein occlusions in this patient. Again, diabetes mellitus, what are the mechanisms that are involved when we say that there are the retinal vein occlusions? Usually, it is the stasis of the blood. The cattle trucking phenomena is quite common in the diabetic patients. So that is basically the stasis of the blood, and the hyperpermeability of the vessels is the pathogenesis that is occurring in patients who are suffering from diabetes mellitus, and then in return it is going to manifest as the vein occlusions in this particular patient. Hypertension, so these are the systemic factors: hypertension, diabetes mellitus, SLE, sickle cell. All of these systemic illnesses are going to further aggravate the condition in a patient, and finally the retinal vein occlusions can occur due to all of these phenomena or factors. Moving on, we have the pressures on the veins. It can be the external pressures even. Then we have the periphlebitis retina. So usually if you have an infectious state of the vessels, an inflammatory condition of the vessels, even that is going to manifest in this particular patient, in which the vessels are being blocked due to the external inflammatory conditions, and that is again going to manifest as the vascular compromise in these patients. Pressure on the veins can even be caused due to tumors. A lot of tumors even can manifest as the orbital tumors, for example. Even the localized tumors can manifest as the pressure on the veins, and finally resulting in the retinal vein occlusions in this particular patient. As you can see, the retinal vein occlusions are basically resulting in the damage to the cells of the retina, and obviously the gangrenous states are quite common over here. This blackish discoloration is not very normal. When you compare this retina or this fundoscopy with a normal patient, you're going to see that this discoloration is basically pathological in origin. Then we have the local causes, which can even affect the vascular structures of the retina, and they can basically have the pressure effects on the vessels or on the veins of the retina. Again, it can be the periorbital cellulitis, it can be the styes, chalazions, the different tumors, blepharitis. All of these conditions can manifest as the pressure symptoms on the vascular structures of the retina. Moving on with the classification of the retinal vein occlusions, as we have discussed the etiological factors, we're going to move on to the classification which is based on the pathogenesis. On one hand, we have the non-ischemic variety, and we have to distinguish this non-ischemic variety from the ischemic variety of the retinal vein occlusions. Dealing in, we have the central retinal vein occlusion. which has basically the ischemic central retinal vein occlusion, and then we have the non-ischemic central retinal vein occlusions. On the other hand, in a lot of individuals, we have a variant, which is basically a branch retinal vein. It can be occluded as well, and it has its own manifestations. It has its own fundus findings over here. So we have to differentiate this ischemic variety from the non-ischemic variety. Clinically, when we look at the non-ischemic variety, it's a milder form of the central retinal vein occlusions on a broader terminology, and the ischemic variety is basically a more severe manifestation of the central retinal vein occlusion. The non-ischemic variety is basically the stasis of the blood that is occurring, the venous stasis retinopathy. This is the other terminology that is used for the non-ischemic variety over here. It's a milder, a moderate form. The visual acuity is less decreased in these particular cases of the non-ischemic variety. RAPT is not present in these patients. That is the afferent papillary defect is not present in these patients. And in the ischemic variety, we have the RAPT positive patients. So this is the main differentiation between the ischemic and the non-ischemic variants of the central retinal vein occlusions over here. And then we have the branch retinal vein occlusion, which has its own clinical manifestations that we'll be discussing further on. Dealing particularly with the non-ischemic central retinal vein occlusion, what are the findings of this non-ischemic kind of a variety? When we look at this, we find that we have the flame-shaped hemorrhages over here, which are not quite severe in this particular patient. We can observe papilledema over here. Sometimes the macula is also involved over here. Sometimes the optic disc is involved. That will have its manifestations. But the major finding would be the tortuosity of the vessels, that is that you can see over here, that you can appreciate over here, and as well as the dotted hemorrhages that are occurring over here. In a lot of patients, we see macular edema, we see the optic disc being involved. So whatever the case may be, we have to write or we have to record these positive findings, and they're most likely suggestive of the non-ischemic CRVO if they are coupled up with a negative RAPD, as well as if the visual acuity is not decreased to much level in these patients. On the other hand, if we differentiate the ischemic central retinal vein occlusion, we will be seeing in the early cases and in the advanced stages. So we'll be discussing both of them in detail over here. When we say the early cases, if you look at this particular findings, this particular fundoscopic findings over here, you're going to observe that there is an engorgement of the retinal veins. So the accentuation of the retinal veins, the engorgement of the retinal veins, and then furthermore, you're going to look for any atherosclerotic process if it is occurring at the vascular level, and if you can see that or if you can appreciate that at the vascular level as well. Then finally, you're going to have the retinal hemorrhages. These particular hemorrhages are basically known as the flame-shaped hemorrhages, as you can appreciate over here in this diagram, which is basically a fundoscopic finding. The cotton wool spots are basically the ischemic areas that you can appreciate. And then we have the edema and the hyperemia. That is one of the key factor or one of the key clinical feature in the ischemic variety of the CRVO. Then we have the breakthrough vitreous hemorrhages that are again one of the clinical feature, one of the main clinical feature over here. So these are the range of disorders. As you can see, these are the range of disorders that are going to manifest and that are going to be suggestive of the ischemic variety of the central retinal vein occlusions, and that is going to help you make a final diagnosis towards that the patient is suffering from the ischemic CRVO. Then finally, we have the ischemic CRVO, that is the retinal vein occlusion, and the late cases, the advanced stages of the central retinal vein occlusion are going to be manifested, or have the ocular manifestations in which the macula is also involved, and obviously the macula is responsible for the central vision in an individual. So if this macular region is affected, that is going to furthermore affect the central vision, that is going to be responsible for the a visual defect in the central vision of that individual. Then obviously when this ischemia is noted down by the body, is sensed by the body, that is going to start a process of neovascularization, which is again, it can be the NVDs, neovascularization at the disc. It can be the NVEs, neovascularization elsewhere in the retina. Then we have the sheathing around the veins. It's another very important finding that is going to give you a clue that it is basically an advanced stage of the central retinal vein occlusion in that patient. The complications of the central retinal vein occlusion would include rubeosus iridis. As we've already discussed, this ischemia is being sensed and neovascularization process has been started on. So that would again going to be resulting in the rubeosus iridis in this particular patient. This rubeosus iridis or neovascularization, which is occurring at the level of the iris, is going to block the angles. And again, the vitreous humor, which is being circulated by the canals of the sclem at the angles, they're going to be obliterated. And then again, it is going to be resulting in a neurovascular glaucoma in that patient. The vitreous hemorrhages are quite common in these patients. Again, as I've already discussed, there are flame-shaped hemorrhages, the posterior chamber hemorrhages, and that is going to be manifested as floaters by the patient. The complaint would be of floaters. Why? Because the posterior chamber is having the vitreal hemorrhages that is going to be detected by the person when you're going to perform the Amsler grid for the visual field defect in that particular patient. The patient would give you a finding of the floaters, that is a blind spot or a visual field defect that is floating in front of that patient. Then we have the proliferative retinopathy as well. That again is basically the cause, again, is the neovascularization that is taking place at the retinal level. We have the neovascularization taking place at the disc, taking place at the macula, or taking place elsewhere in the retina. So all of these would be the findings over here. Sometimes this particular finding of the hemorrhages that are taking place, the flame-shaped hemorrhages are taking place, they are given a characteristic name of a tomato splashed appearance due to this severe splashing phenomena, hemorrhagic phenomena that is taking place at the retina. So it's very characteristic of the ischemic variety of the central retinal vein occlusion. On the other hand, we have the presentations of the branch retinal vein occlusions, and that would include a hemicephalic occlusion. On the other hand, we have a quadrantic occlusion in which a wider area is being affected by this branch retinal vein. And then we have these small branch occlusions along with that. Whenever we have these small branch occlusions, it can affect a very small area of the macula. But still, if this small area is being affected, or if there is a branch, usually it's a cilioretinal branch that is supplying the macular region. So if that is affected, then the central vision is being affected. And then finally, we have the peripheral branch occlusions. So it can be a central vision or that is being affected, or it can be a peripheral vision that is finally being affected by a branch vein occlusion in that particular patient. On the other hand, we have the retinal edema, we have the hemorrhages, the chronic macular edema, then we have secondary glaucoma, a very key factor, a clinical feature that is seen in the branch retinal vein occlusions. We have neovascularizations termed as NVDs, NVEs, and then we have the management guidelines that are being performed for the retinal vein occlusions. We should keep in mind the clinical features or the fundoscopic findings for the branch retinal vein occlusion and the central retinal vein occlusion. After that, we'll make a final diagnosis towards whether it is a central retinal vein occlusion or a branch retinal vein occlusion. And then finally, we're going to decide the management modalities or the treatment modalities out there that can be effective, that can prove to be an effective treatment therapy in these patients. The ocular examination is being carried out in these patients. Visual acuity is severely decreased in the ischemic variety of the central retinal vein occlusion. Fundoscopic findings would reveal the cotton wool spots, the flame-shaped hemorrhages, the neovascularizations that are being taking place. And then we have an increased intraocular pressure that is sometimes the baseline cause for the development of the retinal vein occlusion in that particular patient whom we're talking about. So then we have gonioscopy, which is being performed by the Goldman lenses. We have the 70D lenses. We have the high definition lenses being used just to see the fundus of the individual quite clearly and appreciate the changes that are taking place at this level. The undilated slit lamp examination again is being carried out to find out the positive findings in that particular patient. The ocular investigations would include Goldman perimetry and ERG evaluation for that particular patient. The fundus fluorescein angiography would give you a final diagnosis towards whether there is a vein occlusion, if there is a decreased flow towards a particular vein. That would be basically giving you a final view towards that. And then the optical coherence tomography. These are the high definition tests that are being performed to rule out this vein occlusion in a patient. Systemic examination, we should measure the blood pressure to rule out hypertension, the blood glucose levels, fasting as well as random, to rule out the diabetes mellitus. Hypercoagulability states, that is, we have a lot of states, for example, the antiphospholipid syndrome, the use of the contraceptives, dyslipidemias, the cholesterol levels are going to be noted down in these individuals. And then finally, we have the cardiovascular diseases that are going to be noted down, or if the patient is giving you a history of the cardiovascular diseases in that particular patient. The differential diagnosis would include a diabetic retinopathy, and that is usually bilateral. So a vein occlusion can be unilateral in a lot of cases, while on the other hand, a diabetic retinopathy is usually bilateral. On the other hand, these symptoms can be confused with the ocular ischemic syndrome, which shows usually no tortuosity in the veins, and we have dilated veins in these individuals, which is quite contrary to the central retinal vein occlusions. The treatment modalities would include treating the systemic and ocular manifestations. So obviously you have to treat the underlying cause in that particular patient, the observation and monitoring. You have to keep on observing the visual acuity in that patient. The ocular therapy in cases with the marked visual loss is again very important. The therapies, the ocular therapies would include the medical therapy in these patients of the retinal vein occlusions. This medical therapy would include the intravitreal anti-VEGFs, and these are basically the growth factors that are being injected in the retina. And then we have the intravitreal triamcinolone just to obliterate any vein occlusions. The surgical modalities would include a pars plana vitrectomy just to treat any retinal detachments that are being taken place. Then again, we have the ocular therapies that are done by the photo laser coagulations that are being taken place, including the grid lasers on one hand, not recommended for the macular edema in the vein occlusions. We have the pan-retinal photocoagulation, in which the whole of the retina is being involved for the laser therapy. And then we have the scattered laser photocoagulation techniques that are being used in this particular patient. Once we are done with this vascular accidents that are being taken place, we are going to study the hypertensive causative factors that are going to relate towards the retinopathy in these particular patients. Hypertension can be a chronic hypertension, or either on the other hand, we can have the malignant variety of the hypertension as well. They have their own manifestations. It can even lead to the cattle trucking phenomena. It can lead to the complete visual loss even in a patient. The visual acuity is quite affected in these patients. What are the pathogenesis towards what are the pathological mechanisms that come into action whenever the patient is having a high blood pressure? A hypertensive retinopathy is basically just when it is affecting the retina of the individual. Sometimes along with the retina, the choroid plexus is also affected in these individuals, which is known as the choroidopathy in these patients. And then on the other hand, we can have the optic nerve being affected by this hypertension or by this raised blood pressure level. So all of these mechanisms involving the choroid plexus, involving the retina, involving the optic nerve. So all of these involvements are going to be collectively resulting in the decreased visual acuity in patients who are suffering from hypertension. The pathogenesis would be basically the vasoconstriction that is occurring due to the hypertension. It is resulting in the retinal arterioles being constricted. We can have the peripapillary choroid arterioles being constricted, and then we can have the particular choroidal vessels being constricted. So all of these constrictions is going to result in a compromise of blood flow towards the retina, and finally, obviously, it is going to result in the gangrenous or in the cell loss that is occurring at the retinal level due to this vasoconstriction that is taking place. Then finally, we have the arteriosclerotic changes that are taking place. So all of these atherosclerotic changes that are taking place due to the hypertension, that is going to further block the blood flow towards the retinal structures. In other words, we can say that the retinal artery occlusion, that is basically the central retinal artery occlusion, can occur due to these hypertensive retinopathies in these patients. And then we have the increased vascular permeability that is taking place due to an increase in the blood pressure flow in the vessel walls, and that is going to furthermore result in a vascular permeability that is being increased, an edematous state that is going to take place due to this increased vascular permeability. The clinical types would include the chronic hypertensive retinopathy, that is quite characteristic over here. And then on the other hand, we have the malignant or the acute hypertensive retinopathy that we can basically differentiate hypertension into a normal chronic hypertension. On the other hand, we have a malignant variety, which has a shorter course, but the end results or the end organ damage is quite hazardous in these conditions of the malignant hypertension. So in this you can see there is a completely, the atrophic changes are complete, the retinal damage is quite aggressive in this case of the malignant hypertension. The chronic hypertensive retinopathies would be basically encompassing the hypertension with the involutionary sclerosis over here. The augmented arteriosclerotic retinopathy is compromised in return due to this sclerosis phenomena that is taking place. It is usually taking place in the elderly patients or in the old age patients. On the other hand, we have the chronic hypertension with compensatory arteriolar sclerosis that is taking place. It is usually associated with benign nephrosclerosis, and it is most commonly occurring in young patients. So on one hand, we have a younger lot, and on the other hand, we have the elderly patients. In younger patients, we have the benign kind of a compensatory hypertension conditions, a chronic hypertension that is being taken place. In the elderly patients, we have a more malignant kind of a variety over here. The fundus changes would include all of these changes, the tortuosity, the nicking phenomena that is quite common due to this hypertensive changes that are being taken place over here. Even you can see you can appreciate the flame-shaped hemorrhages over here in this particular ocular findings, or in this fundoscopy that is giving you the pictures that are quite characteristic of the hypertensive changes that are taking place in the retina or in the fundus. The arteriovenous nicking, it's of different types. So we have this Salus sign that is quite an acute kind of a nicking phenomena that you can appreciate over here. Then we have the Bonnet's sign that is basically giving you an overview of the vascular formations over here. And then we have the tortuosity or the accentuation of the blood vessels that is known as the Gunn's sign. So these are the vascular changes that are occurring at the fundus. And these all are basically related to the chronic hypertensive retinopathies. Then finally, we have the retina that is being affected due to the chronic hypertension, the flame-shaped hemorrhages, the cotton wool spots. This is a diagrammatic review just to give you a memorization point. Whenever you are going to memorize what are the changes that are going to take place due to the hypertension, this diagram would give you a mesmerizing view or memorizing view towards it. The retina is affected, the cotton wool spots are there, hemorrhages, flame-shaped kinds are there, and then we have the hard exudates that are being formed due to the increased vascular permeability caused by the hypertension, and sometimes the macula is also being affected due to the hypertension in these patients. The malignant hypertensive retinopathy, we have the acute, it's an acute kind of a stage, it's an emergency kind of a stage. It is occurring in the old age patients, the acute hypertensive choroidopathy in which the choroid plexus is affected. And then we have the acute hypertensive optic neuropathies. So it can be the nerves, it can be the choroid, and it can be the whole retina that is affected in the malignant kind of the hypertensive retinopathies that are taking place. We have different classifications towards the staging phenomena of hypertensive retinopathies. Mainly, we have the Keith and the Wagner's classification, ranging from grade 1, which is of a mild, grade 2, which is of a moderate kind, grade 3, which is a little bit severe, involving the retina, involving the macula or the optic nerve, having the flame-shaped hemorrhages, and grade 4, which is having all the features, having the hard exudates, having the flame-shaped hemorrhages, and it's the complete severe form of the hypertensive retinopathy. Then we have the Shee's classification. The staging of the retinopathy would include different changes over here. Mainly, we have stage 0, in which we have the characteristic findings. There is no visible retinal abnormalities over here. Stage 1 would have the diffuse arteriolar narrowing and no focal constriction. Stage 2 would have the more pronounced arteriolar narrowing with focal constriction. And stage 3 would have the focal diffuse narrowing with the retinal hemorrhages. And the stage 4 would have the exudates, the edema, the hemorrhages, and the optic disc edema. So this is again one of the classifications which is based on the severity of the condition over here. Finally, we have the Wong and the Mcintosh classification over here. We have a milder retinopathies, we have a moderate, and then finally we have the accelerated retinopathies having the exudates, having the flame-shaped hemorrhages, as you can appreciate in all of these pictures. If it is involving the macula over here, it is involving the optic disc over here, so it's a more severe kind of a variety, or an accelerated or an advanced stage of the retinopathy over here. The management would include the mild retinopathy can be treated by a control in the blood pressure, the moderate retinopathy obviously a control in the blood pressure, as well as it is coupled up with the assessing the vascular risk factors over here, the risk reduction therapy that is given, the accelerated retinopathy in which we control the blood pressure, coupling it up with the antihypertensive management in the accelerated kind of conditions. On the other hand, we have retinopathy in the pregnancy-induced hypertension. The features would include the narrowing of the nasal arterioles at this level over here, and then we have the persistent spasm of the vessels, which is causing the retinal hypoxia. The retinal edema and the exudates would be releasing over here due to the same mechanisms that were occurring at the hypertension level that we've already discussed. The retinopathy that is produced due to the pregnancy-induced hypertension, there are the reversible changes of the retinopathy. In pre-organic stage, we just give a conservative treatment. We control the blood pressures. Antihypertensives are sometimes prescribed. Along with this conservative kind of a treatment, pregnancy may justifiably be continued if it's not a malignant kind of a hypertension. Then the advent of the hypoxic retinopathy, the termination of pregnancy is sometimes suggested in this kind of a condition. Or permanent visual loss or a life loss is being suspected, then you basically terminate the pregnancy. Moving on to the diabetic kind of retinopathy and what are the changes that are occurring at the fundus level whenever a patient is suffering from diabetes mellitus. So this is a particular picture of a patient who is suffering from diabetes mellitus and his fundus or his visual acuities being affected. The cotton wool spots and all of these phenomena are quite characteristic of a diabetic retinopathy. The risk factors would include the age of onset of the diabetes, the duration of the diabetes, and then finally if it is coupled up with pregnancy or not. The risk factors are sometimes hereditary, poor metabolic control, gender. Females are more affected by this kind of a condition, smoking, obesity. All of these are the additional risk factors towards the development of a diabetic retinopathy in a patient. So the pathogenetic factors which make an overlay towards it are the vascular and the hematological changes in the diabetes mellitus. The thickening of the capillary basement membrane is the final pathogenesis over here. The capillary endothelial cell damage occurs. There is a deformation of the RBCs and the Role synthesis. There is basically a cattle trucking phenomena, which is known as the Role synthesis. Increased stickiness, hypercoagulability states of platelets and plasma viscosity, loss of capillary parasites, and all of these changes that are taking place are going to result in the microvascular occlusion. That is going to result in the retinal ischemia, and which further is going to result in the capillary leakage, neovascularization, and hard exudates, which are characteristic of a diabetic retinopathy. And then we can have the microaneurysms as well. So these are the clinical features, and we discussed why these clinical features are taking place. What is the pathogenesis behind these clinical features? The hemorrhages, the edemas, the AV shunts, that is basically the arteriovenous shunts that are taking place over here. All of these phenomena, the pathogenetic factors that are taking place in which we have a loss of capillary parasites is going to result in the increased viscosity or the increased permeability of the blood vessels. That is going to result in a capillary leakage and microaneurysms as well. We have a non-proliferative diabetic retinopathy, which includes the ophthalmoscopic features, microaneurysms. On the other hand, we have retinal edema, we have retinal hemorrhages, hard exudates, and cotton wool spots, and we've already discussed the pathological basis behind these findings in a patient of diabetic retinopathy. The classifications include the ETDRS study classification, in which we have a mild non-proliferative diabetic retinopathy, we have a moderate non-proliferative diabetic retinopathy, we have a severe non-proliferative diabetic retinopathy, and we have a very severe non-proliferative diabetic retinopathy. The proliferative diabetic retinopathy, in which we see the neovascularizations at the discs without the HRCs, and sometimes we have the neovascularizations with HRCs. That is the hard exudates that are seen over here. A diabetic maculopathy in which the macula is involved. Hard exudates are found over there. Cotton wool spots are found over there. Clinically significant macular edema is basically in which we see a thickening of the retina at the macular level, hard exudates are formed, and the zone of the retinal thickening is formed. So these are the three features of maculopathy that is taking place due to the diabetes mellitus. Finally, we have the clinico-angiographic classification of diabetic maculopathy, which has the focal exudative maculopathies, diffuse exudative maculopathies. We have the ischemic variety, and then we have a mixed variety of the maculopathies in which we have the exudates as well as the hemorrhages. The OCT classifications include the non-tractional diabetes mellitus, and we have the tractional edema over here. The maculopathies or the macular edema, which is non-tractional, can be related to the spongy thickness of the macula, cystoid macular edema, or the neurosensory detachments over here. The tractional macular edema can be when there is a vitreofoveal traction and there is a taut posterior hyaloid membrane due to this traction that has taken place. Advanced diabetic eye diseases can occur in which there is a thin membrane that starts forming over the retina and the visual acuity is severely reduced over here. The management would include obviously conservative management towards the diabetes mellitus, the control of the diabetes mellitus, and obviously the urine examinations, the lipid profiles, as well as a 24-hour urinary proteins. All of these investigations are being carried out to manage the patients. Renal function tests, blood sugar estimations, hemograms, as well as the glycosylated hemoglobin, which gives you an overview that is basically an HbA1c. That gives you an overview towards the control of the blood sugar levels over the past 6 months. Advanced diabetic eye diseases, we perform FFAs and we perform optical coherence, that is tomographies, OCTs are being performed in these patients. The treatment would include metabolic control of the diabetes mellitus. So the mainstay is to treat the causative factors. And then finally, the intravitreal growth factor drugs, the intravitreal steroids are given. And then finally, the photocoagulation, that is the laser therapies for the complete retina or for a particular area of the retina that is involved or that is damaged due to the diabetic retinopathy. The focal treatments are sometimes given. We have the grid treatments to treat a range of area, and then we have the pan-retinal photocoagulation involving the whole of the retina in this particular case. After the laser therapies, we have the surgical treatments out there involving the macular edema, the tractional kind, the non-tractional kind, in which we perform the pars plana vitrectomy for the patient. The advanced proliferative diabetic retinopathy with dense vitreous hemorrhages involving again the pars plana vitrectomy and the removal of the opaque vitreous gel. Endophotocoagulation, that is involving the complete retina. Advanced proliferative diabetic retinopathy with extensive fibrovascular epiretinal membrane. Again, we're going to perform the pars plana vitrectomy, removal of the fibrovascular epiretinal membrane, and at the end, we're going to perform the end photocoagulation in this patient. The advanced PDR with the tractional retinal detachment, again, the pars plana vitrectomy, and the aim is to reattach the detached retina in this patient. Scleral buckling and internal tamponade is also given just to avoid the retinal detachment furthermore. So in this particular lecture, we summarized the different vascular accidents that can occur at the retinal level. It can be the vein occlusions, the central retinal vein occlusions, or either the branch retinal vein occlusions. On the other hand, different systemic diseases, mainly the hypertensive conditions as well as the diabetes mellitus, which can have their ocular manifestations that are discussed over there. So that is the end of this lecture. Thank you for watching sqadia.com.